Before we start, a quick note that this episode has been in the pipeline for a little while now. It was recorded in February, and a lot has happened around Steward Healthcare since then. But this episode is about nonprofit hospitals, and we hope it will be just as interesting now. Here in Massachusetts, we've recently been reminded of the risks of the for-profit hospital ownership system, and also private equity's impact on the stability of the broader healthcare system because of the crisis at Steward Healthcare. But nonprofit hospitals can also face controversy about their business practices. A new book, The City and the Hospital: The Paradox of Medically Overserved Communities, argues that urban hospitals can hurt the neighborhoods they operate in as much as they can help them. I'm Jennifer Smith, and this is the Codcast, Commonwealth Beacon's podcast about policy and civic life here in Massachusetts. Today, I'm joined by two co-authors of The City and the Hospital, Jonathan Wynn, Chair and Professor of Sociology at UMass Amherst, and Dan Skinner, Associate Professor of Health Policy at Ohio University. So, let's take a look at nonprofit hospitals. Jonathan and Dan, thanks for being here.
Thanks for having us.
Yeah, it's great to be here.
So this is a tricky time right now to be delving into hospitals' impacts in Massachusetts because, as we know, on the eastern side of the state, Steward Healthcare System is in such dire financial straits that its 9 hospitals are currently in limbo. But let's frame out what we're talking about today, which is nonprofit hospitals. So, Dan, Jonathan, what's the pitch for nonprofit hospitals broadly, and what's the promise of these facilities?
Well, one of the first things you need to do when talking about hospitals is to kind of dispel some myths. The word nonprofit sounds very exciting and important, and it is. But as we point out in our book and in our research, being nonprofit does not mean you don't have billions of dollars of revenues, that you don't have if you're a private nonprofit, which most hospitals are in the United States and in Massachusetts, you still have public responsibilities because you don't pay the full spread of taxes that for-profit hospitals would be paying.
One of the things that we're interested in is not just hospitals, but hospitals as they are situated in cities and in urban areas. And so when we look at one of our cases, for example, Hartford, we see that there is not just hospitals, but also education facilities and also state institutions that are also nonprofit and therefore also are not paying into the municipal coffers. And so it's kind of in a larger ecosystem that we're looking at hospitals and their obligations to their communities.
So places like Massachusetts, places like Hartford, we are going to be talking about Ohio as well. You do tend to see, as you noted, Jonathan, kind of the meds and eds reputation of some of these places where there's a very high concentration of very educated folks. There's a very high concentration of educational institutions, hospitals. And so it would seem to plenty of people, like if you live in these areas, then of course you would have access to this very high quality of service. But the awkward paradox that you folks have explored that we're going to talk about today is health outcomes are often worse around these hospitals, and we are going to break that down into subparts. Let's start with maybe the biggest one, which is what does worse look like?
One of the things we tried to focus on is breaking down the geographic areas, right? And so we tried to compare on several different health outcomes, the immediately surrounding area, and then kind of create rings around each hospital. And so we had the contiguous census tracts around the hospital, and then the ones around that, and then the third row around that. And that's how we were able to track and look at the health outcomes as you move closer and closer to the hospital, what those health outcomes look like, and then also looking at them, kind of nationwide and those nationwide comparisons as well. And so that's the kind of focus that we looked at when it comes to these health outcomes. That's the first thing I'd say.
And then thinking about the disparities in health outcomes that you were looking at, where there are certain kinds of medical conditions, certain treatments, certain issues of longevity, what were you trying to measure?
I mean, look, here's one of the paradoxes, right? Some of these hospitals, take like Mass General or Johns Hopkins or, any of the Cleveland Clinic, the big flashy hospitals that everybody thinks about when we think about the largesse of American healthcare. And they have incredible accomplishments happening inside their walls. One of the things that we do in the book is we notice that doesn't necessarily, not only does it not translate to local communities, but hospitals actually turn out to be pretty poor neighbors a lot of the time and actually have negative effects. And just think about your local hospital and what's around it. What's it like to live near a hospital? Who wants to live near all that noise and traffic and everything? So on the one hand, it would seem like, well, that you're right there. You would have fantastic access to healthcare services. And in some cases, that's true. But in other cases, that's not really the big story. That's not the headline. The headline is what happens to those local communities because of the social effects. So we're talking about things like diabetes. We're talking about things like cardiac care. I mean, the Cleveland Clinic here in Ohio, where I am today, everybody knows the Cleveland Clinic, an amazing internationally renowned institute. If you have a really serious heart condition, you want to be at the Cleveland Clinic most likely. And yet you look outside, and we did. We stood in the Cleveland Clinic building and looked outside at surrounding neighborhoods, and you could see the entrenched poverty. You could see all of the preconditions that we know lead to poor health. So, life expectancy drops immediately right outside the doors of a lot of these hospitals. Any number of health metrics will track with this basic logic.
And if we could go back just a little bit kind of in time, you mentioned that you can sort of see what's happening around the hospitals. How did you end up getting into exploring this particular research question? Was there a particular hospital? Was there a particular neighborhood?
I'll say, so Daniel and I both went to the Graduate Center at in New York City at the CUNY Graduate Center. And so I was a sociologist who's focused on urban areas and urban communities, and Dan is a political scientist whose focus is on health policy. And so the two of us actually had lunch, and we were talking about, the two of us, kind of what would a project look like where we took these two perspectives, and how would that kind of, where would that land? And so it actually came more from our two perspectives and seeing what kind of puzzles we could actually look for. And we started looking at hospitals as an interesting focus of thinking about the relationship between health and cities. And that's why we ended up focusing on this. It wasn't on a particular hospital itself.
I'll add too, so I'm in Ohio. I'm in the Columbus area, so central Ohio. And I've been doing work for about 10 years now with the local children's hospital, Nationwide Children's Hospital, one of the top ranked hospitals in the country, do fantastic work for kids. But, as John knows, as an urban sociologist, and I've been lucky enough to talk to, geographers and things like this, people who look at the world from this perspective. Right next to Nationwide Children's Hospital is one of our major interstate highways. Those interstate highways, as we know, and this is true in the Boston area as well, just destroyed neighborhoods around the country as they were built. That had huge health consequences. And is it a fluke that hospitals end up near interstate highways and things like that? Well, in a way, it's nice to be located there. But then when you start to look at what happened to those communities when they were built, so if you go back to the siting and the founding of these places, as geographers know, it's not a mistake that these places end up in fairly vulnerable communities, because that's where they can kind of, hospitals are insatiable expanders. And how do you expand when you have a community that can push back? We looked at the University of Colorado Medical Center in Aurora, Colorado. That system had to leave the downtown Denver area because it was pretty clear they couldn't push around the local communities. They couldn't expand anymore. So they left to one of America's preeminent immigrant destinations, right? So when you start to look at it from this perspective, hospitals appear very different than, just a U.S. News and World Report ranking would tell you.
So how do you piece apart these kind of intersecting issues? So it's not specifically, of course, that, the hospitals are causing a certain type of poverty, but you often see, for instance, that they're sited in places that are more urban centers. They tend to be surrounded by lower income communities, often communities of color. And when you're talking about, for instance, the relationship between proximity to hospitals and health insurance coverage, for instance, how are you thinking about that as being related more to the demographics of the area in which they're cited versus kind of a cause and effect situation of, if a hospital is there slowly over time, it becomes less desirable for folks who aren't maybe in lower income communities or in kind of worse straits. So how did you untangle these very overlapping demographic and coverage questions?
Well, that's a great question. I think that's the question itself is hard to answer because it is difficult to untangle these things, right? Obviously, poverty and unequal health outcomes are interlinked, right? And so when you look at these neighborhoods, you can say, oh, these are impoverished neighborhoods, and so of course you're going to find worse health outcomes. So one of the things I think that we're trying to point to is this fact. So yes, poverty does lead to unequal health outcomes, but why is it then that you have these premier institutions, these citadels for health that cannot address those needs? What are the barriers that exist, both culturally, kind of symbolically, emotionally, socially, that prevent people from having access to it, right? So yes, I think it is a puzzle. That's why we call it a paradox.
I'll add as well, and I want to be really clear on this point, because when we first started reaching out to hospitals to talk to them, as you can imagine, I mean, hospitals are famously secretive entities, right? Any degree of transparency coming out of hospitals, even nonprofit hospitals, has to be kind of wrested out of them through state and federal entities and the IRS, et cetera. But we spend a lot of time in this book praising hospitals. And I expect some critics of the book will say you're a little too nice to hospitals at times, which is not how the PR folks at hospitals are going to see it, because they're pretty averse to kind of anything other than we save lives and we're wonderful, et cetera, et cetera. But John and I, for better or worse, we're social scientists, and it's our job to kind of complicate simple things. And, there's amazingly good things going on in hospitals, and then there's amazingly complicated things. And I don't think that the vast majority of what we uncover in this book is because of malignant intent necessarily, or, of course, there's going to be, a mixture of things going on. But, when you're that big and when you're that powerful and when you're not paying, taxes into school systems and other municipal services and things like that, it's a public service. It's a public imperative to actually ask, what are we getting in exchange for these tax giveaways, right? For, all the kinds of things that happen with siting. So we're asking a hard question that kind of pushes against a narrative, which is we love hospitals. We're born in hospitals. We hope that hospitals do life-saving things. But, when you look at a hospital from this perspective, it's a way more complicated thing than, George Clooney or something like that.
So let's talk a little bit about that tax question here, where you have the sort of stated charitable mission of these hospitals. That means that they fall into certain kinds of tax rules that other organizations might not. I'm sure plenty of people around Massachusetts are also familiar with the concept of this debate happening around universities, for instance, the concept of payments in lieu of taxes, the question of what do these kind of large, air quotes and not air quotes, charitable institutions owe in a literal sense to their communities around them. So either Dan or John, which of you would rather kind of break down the tax status weirdness of the nonprofit hospital?
I could start. So first of all, there was about 6,000 something hospitals in the United States last time I looked, right? And that number changes here and there. A little more than 50% of them are classified by the IRS as nonprofit private, which means that they get substantial tax breaks to do their work, with the idea that there's supposed to be what they called community benefit, which is, in some cases, and this has changed over time. And also, one caveat, one of the big criticisms and the things we get into in the book is that there's a lack of clarity about exactly what it is we're asking for here. But the basic idea, and if you talk to most people in Congress who, passed these provisions, these hospitals are supposed to be giving back what they get in tax breaks, almost, to the tune of 100%. But then there's a question of what counts. So they don't like what they get paid for Medicaid. Well, can they write that off? Yeah. There's charity care, and most hospitals are involved in some kind of form of charity care and are taking care of patients who can't pay. So, once you add it up, then the question is, what are these hospitals doing to justify these pretty extraordinary tax breaks? The Affordable Care Act turbocharged this to some degree. Community benefit's been around since the 60s, but the Affordable Care Act tried to take a little bit more of a clear whack at it and say, no, it's time to start looking at these institutions to figure out what's expected of them. Every couple of years, hospitals now have to declare in a public on their website, and listeners can go to their local hospital and find this if they're private nonprofit. They're supposed to declare exactly what their priorities are. They're supposed to do a study to find out what the needs in the community are. And the numbers are supposed to be fairly transparent.
And then I think what I would add then is what the work that, to try and match up what is it that they are getting as far as tax breaks go, and what is the community benefit that these hospitals are giving. That work is great. We're grateful for the fact that the Lown Institute actually does that work. And so what they do is they come up with a fair share ranking for all these hospitals to be able to kind of do that work for us. And that we rely on this work in the book. And so before the podcast, I went and looked at what the different ranking is in Massachusetts is for the Lown Institute and where they rank. So the U.S. News and World Report has a kind of somewhat famous or infamous ranking where they take a look at hospitals and the best hospitals in Boston, Massachusetts. What they do is they look at, it says so on their website, hospitals are ordered according to their performance in complex care in medical specialties, such as cancer and common procedures and conditions like knee replacement and heart failure. Right. But then the Lown Institute goes and they look at questions of health equity, value of care, patient outcomes, and what they do for their communities. Right. And so if we look at the ranking number one, the U.S. News World Ranking for 1, 2, 3, and 4 in Boston, Brigham and Williams and Women's Hospital, Massachusetts General, Beth Israel Deaconess, and Tufts Medical Center. Those are 1, 2, 3, and 4 when it comes to the U.S. News World Report ranking. But when it comes to the Lown Institute, the ranking is exactly the reverse of it. So the best of those 4 is Tufts Medical Center and comes in 13th in the state and gets an A ranking. Beth Israel is 24th in the state out of 55 and gets an A ranking. Mass General is 39th in the state, gets a B grade. And Brigham and Women's Hospital is 43rd out of 55 when it comes to this ranking and gets a B overall. And so this work, Dan says for better or worse, we're social scientists, so we're able to take that data and look at that and build off of that, and to see what exactly is the benefit.
And the stakes here, we should note, are pretty high. I am immediately going to go back on my promise not to talk about Steward, because there's been some very good reporting at places like GBH about essentially what happens when hospitals that have pledged large amounts of community benefits, for instance, then essentially renege on those promises. So GBH had said, the Steward healthcare system said that the hospital backed away from more than $600,000 in community giving. So you've got not just the taxes that you're paying in, but also kind of benefits that are supposedly going to community organizations. So talk a little bit, if you could, about what happens when you have that kind of chain of reliance. If you've got communities that are depending on these hospitals for kind of pledges or an expectation of giving, and then they don't end up either coming through in full or perhaps at all.
I should say, before I make any other comment that, of course, the American Hospital Association and the Massachusetts Hospital Association, I forget, it has a specific name, but they don't like this, right? And they disagree, and they take great issue with the Lown data. So there's an inability to have this conversation in a serious way that I think undercuts all of this. I'll give you one of the data points that might help answer your question, Jennifer, is so Massachusetts is one of these states where the total amount of medical debt that's out there is actually equivalent, about, according to, the best we can tell, to the fair share deficit of these hospitals. So there are people who are strapped with credit card debt and other forms of medical debt from healthcare they received, and it's about equivalent to what is believed, based on Lown data, et cetera, these hospitals actually should be giving back to the community. The Affordable Care Act targeted this specifically, and Congress said these private nonprofit hospitals cannot have overly aggressive debt recovery tactics. That's also a service to the community, which is letting that go a little bit and realizing what that can do to a community. So The consequences are really tied into the broader discussion about the American healthcare system, about what it's like to be afraid to go to an emergency department, that it's going to ruin you financially. Racism. We talked, for example, to people who might live next to a hospital, but if something happened to them, they would try as hard as they could to get across town to another hospital because that's the one they felt they would actually be welcomed at, right? So hospitals are complex things, and in New England, there's a whole ethnic and religious orientation to a lot of these communities and the histories of these hospitals around reproductive health care, all sorts of things. So really, there's a question of what does it mean to be a local community hospital, and what should it require of you in terms of openness and access?
In my heart of hearts and in my background, I'm a housing and land and development reporter, kind of by training in nature here. And John, you brought up, of course, the question of sort of sprawl, the literal use of land that these hospitals are taking up here. I would love it if you could kind of talk to me about sort of not just how they move and end up siting themselves, but also what the impact is when they do sort of eat neighborhoods.
Yeah, Dan says that when you're in the hospital and you look out, what do you see? You see this poverty. But the flip side of it is also what we do in the book. We are in the neighborhoods talking to residents and asking them what do they see when they look at the hospital. And so I think that that's one of the best parts of our book is that we really do go and look at the neighborhood histories, the cultural stories that people tell amongst each other and, kind of in the community. And Dan, intimates this as kind of there's a cultural leaning towards maybe a hospital that might be further away rather than one that's closer. And when we did these community interviews with a lot of the folks in all three sites, we heard a lot of stories about hurt and pain of the acquisition of property and what that meant to a community. So you might have somebody who saw their home be purchased, and at the time they wanted to sell that house because it was amount of money was being offered that was too good for them to pass up. Then to pass by their old home and to see that the land isn't even being developed. It's so there's one story which is like, oh, it's being developed, and that's how sad is it that it's being developed, so ostensibly for a good for a hospital. Right? Because the narrative we have is like, what could possibly be wrong about, addressing health? But it's not always the case. In fact, I think it was in Cleveland, in fact, where it was one story we had where it wasn't even being developed at all. It was the land was being captured and held. And then what was it being used for? Maybe it was for a parking lot. Maybe, maybe it was for just being held. So I think we do track that a little bit. And we talk in one of our chapters about the kind of development of communities and the hospitals do. On the one hand, there's these different strategies that they do to develop community when it comes to employment, procurement, and those kinds of things. And we're happy to talk about that too. But then there's also this kind of development along these spoken hub model of kind of looking out, I call it corridor vision, so instead of tunnel vision, it's kind of a corridor vision. How do we develop a corridor, a health corridor, or an arts corridor, or something like that, and how hospitals very much participate in that, acquisition. I recall one time that we were interviewing somebody and they said, oh yeah, we've got plans 20, 30, 50 years out. And we're like, oh, we'd love to know. And they're like, oh no, we're not going to let you into that room. But we have them. It exists. I can't remember, Dan. Was that in Hartford? I think that was in Hartford.
I mean, in a way, that's everywhere, right? And it does bring us back to this question of is transparency something we expect from institutions? When we were originally looking at hospitals we wanted to study, we were considering a few others, but it became pretty clear that and these were private but nonprofit hospitals. They regarded their archives as complete lockdown, right? No, not to be touched by researchers or anything. So and you'd probably know this as a journalist, right? Not everybody's happy to give over stuff to you. But even when you're dealing with these quasi-public entities that are in this situation, we think that there's a different story that can be told.
I am so sad that we're reaching the end of our time here. So I did kind of want to ask, are there good models that you found? Is it a relative question? Is it saying, given that there are these sort of limitations on transparency, the kind of nature of the way that hospitals do sort of loom in the middle of these communities, the places that they're sited, where are some hospitals on that scale here? We've talked about the negative outcomes, but have there been any that have tried to kind of grapple with that role and make some changes?
I'll very quickly say that I intimated this is that there are some good things. There are very good programs, I would say, that we identify. So they're so good that in Cleveland, there's an example of a buy local, hire local, live local. So these are programs where they are trying to reinvest in their communities to some extent to make sure that they can procure things locally. COVID meant that supply lines were cut, and all of a sudden these hospitals that were, they're kind of isolated when it comes to procuring goods, hiring folks that are local. What are the barriers that prevent people from being hired in, kind of the lower end of the hospital and get these good jobs that exist on the inside of these hospitals? And third, trying to incentivize residents and hospital employees to be able to live locally within walking distance, grants that are waived if folks live 4 or 5 years in the community, right? So there are some things that we looked at, and in Cleveland, those models are so good. We interviewed hospital administrators in Aurora, and they said we love them so much we even stole the name. We stole buy local and live local. We liked it so much, right? And so one of the things we try and do is to highlight those programs and say these are models that we should be expecting, and we should be seeing more of.
If I could just add one quick point, I know we're short on time, but yeah, amazing work being done all around the country, right? I mean, almost, I wouldn't say every, I don't want to exaggerate, but like lots and lots of these places are doing really inspiring, cool work. A lot of it's pushed by the communities that are addressing historical racism in medicine, dealing with just, they're trying to repair their pasts, and there's a lot of memory work happening at the same time. The question for me as a policy person is, there's a lot of public money on the table here. So Mass General has over $3 billion of net patient revenue, right? We're talking about billion-dollar entities. So while the Cleveland Clinic in Ohio might talk about all the amazing work they're doing, Metro Health, which is a far less rich entity, is actually per capita doing a much better job with community benefits. So we're trying to do that thing where we're saying, look, thank you. We appreciate anything good is great, but we need to approach you as the multi-billion-dollar or the billion-dollar entity you are and ask, what are we getting for this? And the real question becomes then about oversight. Are we getting enough? The hospitals think we're asking too much oftentimes, but I think it's a public service almost to ask the question of, is this a legitimate use of taxpayer monies or lack thereof when our schools and other municipal services often struggle to just, have their ends meet? So it's a complicated question, but we want to praise while we're also saying, but we need to look at the total picture here.
Right, because all of these questions, of course, have kind of a yes, but element to them. If they improve transparency, the question is, well, what if that transparency demonstrates that there isn't a lot going into these organizations? Well, then is there a mechanism, for instance, to then say, well, it should be? Is it enough to just know? Once you know, is it enough to have oversight, or does it need to come with certain enforcement powers? So all of these do seem to be kind of tangled together. What stage are you folks at right now? Are you in the kind of let's just assess the situation, or are you pushing for specific kinds of policy solutions to that question?
Yeah, and in the end of the book, we offer some very clear, sort of audacious in a way, just here are some ideas we have, some of which are pretty heavy lifts within our current political moment, or any political moment, but still, I think justifiable in terms of representative democratic systems and, thinking about progressive taxation and just thinking about public good.
Thanks again to Jonathan Wynn and Dan Skinner for joining me on the Codcast. Thank you all for listening. I'm Jennifer Smith. Our producer is John Gee. Leave a rating and review wherever you're hearing this now if you want to help other folks find us, and email codcast@commonwealthbeacon.org if you want to get in touch directly. We'll be back next week.